Hi to those of you who are just joining. This is Brenna Rabel from Battelle. We're going to be getting started here in probably another minute. We've got quite a lot of content to go today, so we don't want to start too late, but we'll give people a couple more minutes to join. Hello, everyone, and welcome to another MMS info session. As you know, these sessions are offered under the CMS Measures Management System contract, which is led by Battelle. I'm Brenna Rabel, and I oversee education and outreach on this project. Today's session is on the topic of making measure development more person-centered, specifically by applying human-centric design techniques to the development process. So we're joined today by a number of guest presenters. So first you're going to hear from Jayanti Bandyopadhyay from Mathematica Policy Research. Jaya is going to talk you through a real-world example of how these techniques shaped her work on a measure under development. And then you're going to hear from Jennifer Simpkins, who represents Battelle's human-centric design team. And Jennifer is going to talk a little bit more globally about some potential applications for these techniques on the measure development process. You'll also hear from Kim Rawlings from CMS, who's going to talk a little bit about how human-centric design fits into CMS's overall strategy for engaging people in measure development. So as most of you know by now, these info sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics, an effort that also includes a series of newsletters and bulletins, along with special announcement emails, public webinars, and routine updates to the Measures Management System website. A big change this year that most of you are probably aware of already is that these info sessions are being held bi-monthly rather than each month, but these will still focus on a wide range of topics related to quality measure development. Before we jump into today's presentation, I do just want to cover a quick set of housekeeping items. So first, today's session is being recorded. Second, all participants will be muted during the call. We will have an opportunity for Q&A at the end, during which time the lines will be unmuted for questions. You probably are also aware that you can use the hand raise feature for questions or use the Q&A field at the end to type your questions in. And then finally, presentation slides from today's session are going to be posted to the MMS website by the end of the week, and the recording of today's presentation will be posted to the CMS YouTube page at a later date. So here is the agenda for today's presentation. And with that, I am going to pass the ball over to Jay.
Thanks, Brenna. Can you hear me okay?
Yep, loud and clear.
Great, thanks. I'll go ahead and advance the slide. So good afternoon, everyone. My name is Jay Bandyopadhyay. I'm a health analyst from Mathematica. And a little background about Mathematica. So we develop clinical quality measures for various federal agencies, including CMS, and we bring expertise in data, methods, policy, and practice into our measure development and testing work. And we're very excited about this opportunity to share a novel approach we use to integrate human-centered design and practice for measure development, specifically our experience at Mathematica in using human-centered design, or HCD, to generate concepts for a pain management-related electronic clinical quality measure. So for this session, I'll begin by describing what human-centered design is, when it's helpful to use the technique, and why it's important, especially when it comes to patient-centered measure development. After we go over the what, the when, and the why, I'll briefly present a roadmap of the use case we're going to talk about, and then we'll turn to the overview of the how we integrated HCD into the measure development lifecycle phases, after which we'll take a deeper dive into the detail of what happened during each phase of work and how exactly we were able to generate, prioritize, and select a measure concept for that pain management ECQM. And then finally, I'll briefly share some lessons learned from our work. Okay, let's get started. So before we get into the details of the use case in our work, I wanted to begin by giving you a very high-level description of human-centered design. So human-centered design is a technique for developing a deep understanding of the experiences of the person you're developing the solution for. It helps the developer identify the unmet and unarticulated needs of the user to develop solutions to meet those needs. It's a highly collaborative approach, and it creates a way to collect deep insights about people, in our case, patients. So in measure development, high-quality measures of healthcare must be evidence-based and rigorously tested to confirm that they're conveying appropriate conclusions about quality of care. However, patients are the ultimate consumers of healthcare, and as such, their experience and needs and priorities should really drive opportunities for improving healthcare delivery. And it can be challenging to do that at times. So here's just one example of the types of things that we heard from a patient we interviewed during our work. And this is an interview participant with chronic pain. You'll see here they mention what they do day to day to manage pain, asking themselves, does this seem to be a longer-term thing? Is ice helping? Is heat helping? So you can see here that there's a lot to unpack and act on from this experience that's being shared. But as I mentioned, it can be challenging to put the patient voice at the front and center of the work. And HCD is a tool that really allows us to do just that, so integrate the patient voice efficiently and meaningfully into our work. And on the right here, you'll see a visual on how HCD techniques allow us to do that. So they allow us to go beyond the explicit knowledge and into the tacit and latent knowledge that help us uncover those insights that may have been unknown to us and even to patients, and incorporate their voice into the measure development process. So understanding the unique value and potential of HCD can be challenging without seeing it in action. So at the core of the presentation, as I mentioned to you, is the use case to provide a concrete example on how we leveraged the principles of human-centered design. So to start with, this slide shows, specific to our work, when it's helpful to use human-centered design. So reducing the number of unintentional opioid overdoses while continuing to assess the quality of care around acute and chronic pain in light of the ongoing opioid crisis has become a priority for agencies like CMS. So given this, in 2019, CMS asked our team to develop an ECQM that identifies the unmet needs of patients experiencing pain, specifically a measure that assesses whether patients with pain receiving sufficient support with the types of pain management provided. So it goes without saying that pain management is a very complex clinical area. So right away, our team had several challenges to overcome in order to make this effort successful. First, we knew that if we were to conceptualize the measure using literature and expert opinion alone, it likely wouldn't lead us to a concept that would gain buy-in on usefulness from patients if it didn't incorporate their voice and perspective from the start. So we needed to understand if the processes and interventions and outcomes that clinicians may prioritize for quality of care around pain management align with what the patient needs and feels is most important. And so to do so, we needed to understand a way to first define the problem. What is the problem here around quality of care for pain management? Here again, we knew that data from literature reviews and expert opinion alone may not be enough to fully comprehend the scope and spectrum of a problem, especially because the experience and definition of pain management may vary by user. And the measure could risk creating potential unintended consequences like undertreatment of pain for certain populations. So not only were there those uncertainties on how we're going to define the problem in order to create a successful solution, but we weren't quite sure how to go about collecting that information in a way that would allow us to capture the information in the broadest way possible and then narrow down our options from there. So those are the several points that are sort of called out here of when to use HCD and how the use of HCD can help us overcome those issues. So on this slide, so this slide shows really an overview of how the HCD phases worked in our process and helping us overcome those challenges. So to start with, what I'd like to draw your attention to here are the three key phases of human-centered design, which is inspiration, ideation, and implementation. And I want to note that there's no one way to apply HCD, but these are the general flow of the phases. And what's key to note here, especially and important understanding the value of human-centered design integration into measure development is the diverging and converging pattern that you see. So rather than starting with one narrowly focused idea for a concept and collecting data around or testing a single concept idea, the diverging and converging pattern of thinking allows you to start with a broad collection of data from patient experience to understand and define the problem, and then work collaboratively with patients and other stakeholders like clinicians to refine that data into action items that can help with the development of the solutions and the ideas and concepts later on and down the phase. And by using this approach and starting with the patient voice, you are able to keep their perspective in the forefront of the work as you continue through each of those measure development phases, which is really the segue into this next slide here. So the focus of our work and the use case that I'll go over today is really around the first two phases of the measure development lifecycle. So we were focused on the measure conceptualization phase into the measure specification phase, and that's what we'll run through today. So what's in the square outline. And just to show you, zooming in a little bit further, and I'll talk about each of the yellow boxes in the phases later on, is within the measure conceptualization and specification phases, you'll see, we started with inspiration and empathy interviews, then we went on to ideation using literature reviews, developing an ideal candidate measure list, prioritizing that list, before finally in implementation, continuing to refine and submitting the measure materials and the specifications to CMS. So jumping into the specifics of our case now that we've been through the overview. Let me get one more. Okay, so here's the roadmap of the work we did and the high-level steps of the phases I'm about to review with you. So I'm going to talk through three main phases of the work. First, gathering information using empathy interviews, which are really immersive interviews to find out as much as possible about a person's perspective. Here we want to understand the choices that people make and why they make them, and use that information to look for patterns and themes. After that, we convened design workshops with a group of patients and clinicians and used their input in converting those themes from the empathy interview phase into potential measure concepts. Then finally, we validated the list of concepts we generated using evidence from the literature and stakeholder input in order to prioritize them before we delivered those to CMS with our identifying the top concepts for CMS consideration. And before we move on, I want to note one key consideration that we were aware of as a team was that the gap that may arise between the concepts identified by patients that are important and the existing clinical evidence. So that was a risk in that, and then the primary reason why we designed this flow of work in the information gathering phase as such. Okay, so starting with the empathy interviews. Conducting in-person empathy interviews with patients, as I mentioned, provided us insights into their experiences, their mindsets, their behaviors, lifestyles, desires, fears, opinions, and it allowed them to suggest possible solutions, which helped us engage them in problem solving. And the empathy interviews, as I mentioned, are a critical step towards generating the list of concepts that are appropriate for pain management. And coming back to that diamond diagram, this is really that initial divergence step that's allowing you to collect broad information on the issue at hand. So our questions during the interview were fairly open-ended, as they typically are with empathy interviews in human-centered design. And they were informed by our research questions to understand the health outcomes that are most important to patients in terms of pain management, identify their unmet or unarticulated needs around opioid prescribing and use, explored how they define quality around pain management, and assess the face validity of the consensus guideline recommendations against the patient perspective. This is another way that we were trying to address that initial risk of the gap between concepts that may be identified as important by patients and the existing evidence. And so to do this work, we conducted patients who had experience with acute or chronic pain, and then we conducted one-on-one, one-hour semi-structured interviews with them over a few days. And this slide shows really the outcome, or one example of the analysis and what we did coming out of that phase one. So here we have a direct quote from a participant at the top. I think because of the pain in my muscles, they tighten up, so that's where the massage came in, and I tried to swim, just certain things for the muscle part, because I learned that they were interconnected. So I think those alternative therapies, I guess, sort of offset the way my body reacted to pain. So there were other participants who expressed the same idea and qualitative feedback, and the emerging theme that our team was able to discern from that qualitative information was that participants used alternative therapies as their primary source of pain treatment, resorting to opioids only when necessary. And so this was a design guideline that we created using this theme. And that guideline really was to consider whether the provider had already recommended alternative therapies or those therapies had already been tried by the patient. And so this is how we diverged on the information we collected, but then in the second phase, in the ideation phase, we converged again on the specific opportunities stemming from that data and synthesizing them into actionable statements. So the interview data was really the what, and the design guidelines were the so what. And this is one key way where we use the perspective from the patient and kept it at the forefront of our work, coming back as an iterative process to these design guidelines as we generated concepts to understand how are we incorporating the patient perspective we received into those into the generation of potential measure concepts. So you can see here, I'm not going to go through all of the bullets on this slide, but this diverging and converging from inspiration and ideation gave us a lot of diversity around the potential measure concepts and design guidelines that we were able to generate. So you'll see here, themes were covered everything from assessments, education, care coordination and follow-up, and collaboration and trust. So moving on to the next phase, then we conducted, as I mentioned, using the outputs from phase one, these design workshops. And the goal of the workshops was to assess the validity of the themes from the empathy interviews and draft and prioritize a list of initial measure concepts. To do this phase, we recruited new patient participants who have experience with acute or chronic pain, and we also recruited clinicians who would participate in the workshops as well and who had experience with the same clinical topic area. And we conducted 2 3-hour design workshops in the form of focus group with our participants, and then we used all of the both the design guidelines from the previous phase and the data we generated with these design workshop participants to create those list of potential measure concepts. So to show you what that looked like, some of the activities that we conducted with them, one of them was this prioritization activity. So this picture sort of shows that, shows the list of how we took the design guidelines, and then we asked them to prioritize them on different scales. So we would really be able to understand where they would categorize certain themes that were generated from the empathy interview phase. So in this picture, it shows the scale of this is more important to me to less important, and there were others like that looked at empowerment and other criteria during the workshop. Another activity we conducted with them was asking patients and clinicians to collage their ideal pain management experience. And using the method really allowed them to suggest that those possible solutions, and that's where that we were able to really engage them in problem solving, as I mentioned earlier. In some cases, there were patients who didn't have any use of surgery or opioids at all, and they would speak to what that would mean or the types of interventions they would like. And the other advantage that was really important in these design workshop was that it really encouraged conversations across the clinician and patient and discussions, which we were able to observe. So it was tremendously valuable. So after the design workshop days that we had a data analysis workshop day. So as you can see here, we collected a lot of information again, because coming back, we were in the start of that next diamond of diverging yet again. And so we then synthesized and analyzed the vast amount of data very quickly. We're actually able to do it in just a day, which is another advantage of using the human-centered design analysis methods and techniques. And so we used several brainstorming activities throughout the day, like affinity mapping, which helps you gather large amounts of data and organize them into groups. We used dot voting to understand and gain input from the team on the most usable and feasible concepts, and to really initiate that prioritization of the concepts coming out of the design workshops. And really the key point that we found here in using human-centered design as opposed to the typical measure development approach that we've used is that during analysis, we were really able to separate the desirability of the concepts from feasibility. So we were able to go beyond, we were able to really go broad and consider new approaches, and that really led to a range of richer concepts that we could consider and explore. So at the end of that second phase, we were able to ideate over 40 new potential measure concepts in these several areas you see grouped on the right there. And the topic areas really range from the underlying intervention or concept, so everything between the intervention process or outcome were covered across these groups. Going into the final phase of that funnel that I showed earlier, so this was the phase 3 literature review and clinician input. So using the concepts that we generated out of the design workshops, we entered phase 3 to determine which concepts had the strongest evidence base and also gain input on the face validity, feasibility, and usability of the concepts in order to prioritize them. And here again, the goal was to address that key consideration I noted earlier about the gap between concepts identified by patients and existing clinical evidence. So what we did for this work is we convened our opioid prescribing a clinician expert work group, and then we also conducted a literature review on the concepts. Finally, coming out of phase 3, the domain that ultimately rose to the top was the use of multimodal or alternative pain management therapies. Most patients we interviewed during the empathy interview phase and design workshops identified using management therapies other than opioid therapy to be their first line preference. And clinicians also who participated in design workshops reiterated this, and they also drew on non-opioid approaches to pain management. The actual work group members that we spoke with and other stakeholders supported concepts within this domain. And then finally, through the literature reviews, we found a great deal of support in this area as well, which included certain recommendations from the from CDC prescribing guidelines and other professional and state-level guidelines. So what did we learn in using human-centered design in practice for measure development? We learned right away that human-centered design is really an excellent fit for data collection in the measure conceptualization phase. And thinking back to our slide on when we use human-centered design, it was especially helpful because our problem, that is what was most important to patients in regards to pain management, wasn't really well defined or understood. And we were really able to overcome that hurdle. And in addition, we were able to identify through the use of this process insights that were really hidden and unknown to not only us as measure developers, but also patients. And that really addressed that uncertainty and of identifying some of the complexities and risks in some of the concept areas. We also, as I noted earlier, learned that it's the human-centered design approach was an excellent fit for not only collecting but analyzing all of the qualitative data in a very short turnaround, which helped us a lot as measure developers. And then finally, potential unintended consequences or implementation challenges were brought to the forefront right away in using human-centered design. So, for example, patients and clinician participants in the human-centered design activities noted that cost or access of multidisciplinary and non-pharmacologic pain treatments can be a barrier. And before the client invests continued resources in a certain area, or even the measure development team were to pursue a certain topic, right off the bat, we were able to recognize some of the risks and issues with concept and moving it forward. In terms of lessons learned and takeaways from that were specific to our use case, what was really interesting to us is that almost all of the identified, all of the concepts identified as important from the patient perspective aligned with the clinician consensus statements and national guidelines, which is something that was helpful in with the concept that we move forward, and something that will likely help us get more buy-in and refinements later on in development. And then, as I mentioned earlier, given that the definition of pain management varies by user, this case was really a prime example for when data or expert opinion or experience alone was not enough, and we really needed it in combination to ensure success. And bringing the patients and clinicians together in one room and working with them to ideate the concepts, talking about what's most important, what helps, what's most usable, was really helpful. And patients also themselves expressed that they were very engaged and in the activities that we conducted with them. So that's really the core of the presentation. we had in terms of our use case in using human-centered design in measure development for our project at Mathematica. So I want to turn it back to Brenna to continue on with the rest of the presentation. And if there are any questions, to please send them to us after this call. Thank you.
Thanks very much, Jay. That was great. Yep, so now we are going to transition the slides over to Jen Simpkins from the Battelle Human-Centric Design team. And I just do want to note, folks, to please queue up your questions. So if you have any questions or comments on the presentation from Mathematica, keep those in mind, and then you will have an opportunity at the end of the call to raise those either using the Q&A feature in WebEx or by asking them aloud. Jen, go ahead.
All right, good afternoon, everyone. My name is Jennifer Simpkins, and I'm a UX researcher and designer for digital solutions here at Battelle. And Jay did a wonderful presentation for a deep dive insight into how HCD is applied to the measure development process. And we're going to take it back a little bit high level just to kind of go over the general benefits and pitfalls of human-centric design and kind of what to look out for in terms of applying it to the measure development process. So to show just a different visualization of the process, the double diamond is often the common way to show the human-centered design process, but this is just another way to kind of show how insights, user information, ideation, and solutions are ultimately kind of going through this pendulum effect of where you're understanding the user needs, you're generating ideas, you're validating those ideas, you're going through the process together and ultimately wind up with a solution or a set of solutions that would be applicable for solving the given problem at hand. So just to kind of go to the high level benefits of HCD, sort of to get started is basically to find out how to identify all the users and inputs for a given user set here. So with this, it's really imperative to make sure that you have the right people selected for trying to solve the problem. So for example, if you're looking to develop a measure to try to address hospital-acquired infections, you may want to consider everyone that is that has some sort of impact on the patient environment. So that could be the patient themselves, the patient's families, clinicians, maintenance personnel, and other people who might be involved within the patient environment that could potentially feed into the increased risk of an infection. And by identifying all the right users and stakeholders within this process, you'll be able to identify the right problems that need to be solved. So really the core of it is making sure that you have the right people involved for a particular problem area. Again, getting into the research as Jay had described, getting into the empathy side of things is really having an understanding not only of the needs and wants of the people that you are incorporating, but understanding their emotional and physical needs and how that may affect how they view, understand, and interact with the world around them. And the empathic research that you would do in this case is very subjective, and it's very much focused on stakeholder motivations and thoughts. So where this can come in and be beneficial is if you're doing research around reproductive health, addiction, mental health. There may be cultural implications, social stigmas, and other things that may have an impact on in terms of the emotion, the motivations, and the behaviors of the people that you are working with. And next is to gain a full understanding of the problem itself, and to fully understand the people who are experiencing the problem before a solution is designed. So sort of our thought is, a problem well defined is half solved. So that's sort of the principle that we operate from understanding the holistic problem. And doing the early contextual research will help to lead with increased product acceptance or increased compliance with instruction, reducing the rate of use errors. We primarily work with product design here, so these are more product design oriented solutions here. And it can also, to Jay's point, result in faster development timelines. So if you're able to analyze information quicker, get to the right problem areas quicker, you'll be able to ideate your ultimate solutions for measure development a lot quicker as well. And so, again, to kind of reiterate, the whole real goal of this is to get to these solutions that real people will use with your product. And then with a human-centered approach, you will have better compliance or adherence because it will align with workflow. Sort of my approach is that it's easier to change the world than it is to change people. And the better you conduct research, the more time and effort you'll save later trying to force solutions onto people rather than incorporating them into the standard workflows that they already have. So once you identify the patient or the person-centered workflows, you can then consider them as part of an integrated system. And the whole system will lead to an understanding of what is desirable and what can ultimately be combined in with the real world. And sort of the most important factor, again, to Jay's point, is that rigor is definitely required within the HCD process itself. So sort of through all this, it kind of begs the question, it's like, well, can I do this? I'm a human, can I be involved with this process too? And anyone and any stakeholder can be involved within this process, but it is beneficial to have people who are HCD experts and people who have experience within the field to make sure that the process is performed systematically, consistently, and thoroughly. It's important to make sure that you have attention to detail, to listen to what the user says and allow a deeper understanding of the information for a particular question. And it's very difficult to be able to do that with applying your own personal interpretation or trying to solve while asking. So it takes some experience to learn how to ask questions and how to listen and how to capture that without incorporating your own personal biases with that. The evaluations do require a specific skill set, again, making sure that you have an understanding of how to ask these open-ended questions, how to approach how to approach people, how to get the right information out of them. And the measure development process itself is very hard work and needs the rigor of HCD to make sure that you're incorporating the right solutions while minimizing any sort of risk or opening up to potential other issues with patients as well. And so just to kind of give a high-level overview of some HCD tools, typically what we do first when we're working with people is we build a rapport, which is being able to get people comfortable so that they can open up and share important insights. And in the medical space, that's incredibly important as everyone who you'll be working with will be sharing very personal insights into their health. And so having a rapport established is incredibly important. From the open-ended techniques, it is important to have open-ended questions, but also construct them in a way that will help to identify and answer the problems that you're trying to address. And also making sure that you're phrasing questions that are not leading and doesn't place any blame onto the people you're working with as well. So instead of saying, well, why didn't you take your medication on time, you say, well, what was it that was causing you to miss the time in which you would normally take your medication? So just being aware of how to construct questions that don't lead or blame the participants that you're working with as well. With the qualitative synthesis, most of the feedback required in HCD data collection is qualitative in nature and will then have to be translated into quantitative results to look for common themes that will hopefully show up in responses. And then these themes, similar to the boards and affinity diagrams that Jay was showing, is that these themes can then be categorized and evaluated for similarities and differences to capture the nuances and feedback and the resulting impact on the solutions and design recommendations going forward. And then in terms of our interviewing technique, sort of what we kind of fall back on is the 5 whys, which is really getting to the root cause of an issue, and that's critical when doing HCD research. So for example, kind of going down a line of questioning, If you were working with a patient, you might ask, well, why did you have to be readmitted to the hospital? Well, I didn't feel well. Okay, well, why did your health decline why did your health decline after you were discharged last time? Well, I ran out of my medicine. And a lot of people will stop at that last answer thinking, oh, this must be something prescription related. We need to focus on an area with that. But if you keep probing with these questions, you can ask, well, okay, well, why did you run out of your medicine? Well, I didn't get any from my doctor. Well, why didn't you receive a prescription? I missed my appointment. Okay, why did you miss your appointment? Well, I didn't have a way to get there. And so if you kept going down the line of questioning to get to why someone didn't have their medication, you would see that it was actually more of a transportation issue that was at a root, that would be more of a root cause of someone not being able to get the health care that they need. So there's a socioeconomic root to this compared to more of a prescription or medication dispensing issue. So this is sort of where having experience and expertise within HCD can really get you to the root cause of answers and give you better and richer data in order to synthesize solutions from. And then on the other hand, there are some pitfalls to be aware of. So depending on the techniques that you're using for HCD evaluations, it can take a lot of time to design, collect data, interpret results, and iterate on multiple designs. So it's very important to make sure from a budgetary standpoint, it's like, okay, how much are we going to invest in it compared to the value that we might get out of it, and making sure that you're evaluating that at the beginning. HCD is very subjective in nature, and depending on who's being involved in terms of formulating the questions, who might be conducting interviews, workshops, or the other different research methods that are available, there are a variety of interpretations that can be had from the motives and actions expressed or observed by the people participating within the groups itself. And then thirdly, individuals are moving targets, and design needs to evolve with the changing needs of the user. Continued use by a product can also lead to the identification of new needs with increased expertise. And the HCD process must include continual evaluation to be adaptive to potentially changing needs. With limited guarantees, human-centered design does not guarantee necessarily good products, and that also depends on the quality of the research that was conducted as well. So it can lead to improvements of bad ones, more so than creating solutions that would actually solve the problem at hand. And moreover, good human-centric design will avoid failures. It will ensure that products do work, that people can use them, but it may not solve all problems, and it is just one tool in the toolbox. All right, so the blueprint for, let's see here, I think I'm in the section. So the blueprint for the CMS Measures Management System, let's see your section 1.
Overall blueprint, and then talk about where HCD fits in.
Okay. Yeah, so for blueprint for the HCD CMS Measures Management System, so the overview of the guiding principles of the CMS quality measure development and background information of CMS.
Hey, Jen, if you're talking, it sounds like we lost your audio.
Yeah, sorry, I was having some connection issues here.
HCD.
Hey, Jen, if you want, I can jump in really quickly. If you can hear me, I'm going to go ahead and do that.
Yeah, go ahead. Sorry, I'm having some technical difficulties on this side.
Okay, yeah, no worries. Martin, would you hand me the ball, please? Thank you very much. Yeah, so in this section, I think what we really wanted to show you was just sort of how the blueprint is set up to align with the measure development lifecycle, and then sort of inject the different ways that HCD can be applied at each of those phases. So for any of you who've seen the blueprint before, these are the sections that compose it. Just also to give you a little bit of an overview of how the MMS project is set up, just to give you a sense for the overall scope of what we do and the ways in which we apply HCD to our work. We included this graphic here. So, I think most of you know the MMS contract in terms of the blueprint and then in terms of these info sessions, but there's quite a lot of work that happens behind the scenes. And we do our best to sort of employ those user-centric design techniques in all of the work that we do as well. So not just in the actual measure development process, but actually in the tools and resources that we develop. So making sure that the blueprint is developed using user-centric design ideas, making sure that the website, to the extent possible, reflects those principles, and so on. So really, when we think about applying HCD, the way that we're going to talk about it is via the measure lifecycle. So this graphic shouldn't be unfamiliar to any of you. And just to give you a little bit more context, right? So when we talk about conceptualization, this is a huge area where HCD can be relevant. So the time where we are actually developing our measure concepts and narrowing them down to more specific measures for development. You might conduct an environmental scan and request input from a broad group of stakeholders. And this is a great opportunity to do what Jay talked about in terms of starting from a really broad place before you narrow in on something else, where you can get really unbiased, really broad feedback from a variety of stakeholders to help inform the work that you do. During specification, that's where it becomes more narrowed. That's where that sort of diamond narrows again, where you're being really specific about the population and, the setting for your measure, the type of data that you might use. And then the same in testing, right? We know that that's an iterative process, but a big part of that is getting stakeholder input. So talking to patients, talking to providers to help inform the way that you define your measure and to help inform how you might need to go back to the drawing board to make it more effective or more specific. And then, of course, during implementation and then in use and continuing evaluation and maintenance, that's when we actually talk about putting these measures into programs. And the work that we do on those measures doesn't stop just because they're in use. Measures are constantly being evaluated to make sure that they are still meeting the needs of CMS and also of populations. And CMS has spent a lot of time trying to empower users to use the MMS blueprint to take advantage of these standardized processes that we've written out for you and then apply these types of techniques. So really to kind of democratize the measure development process. And what we, I think, have a broader vision of doing is having, HCD experts collaborating throughout these processes as laid out in the blueprint to make sure that we're really using our collective knowledge, both about measure development processes and about human-centered design to optimize the results that we get from measure development and to make sure that the measures that we're creating and using in our programs are really reflecting the needs and interests of the populations that they're serving. So I'm going to pause here. Jen, if your audio is back, I think this might be a good place for you to jump in. And you are still muted in WebEx, so.
Okay. Yeah, sorry about that. Yeah, so I guess the main takeaways, again, Jay really did a fantastic job iterating the detailed nature of HCD. And to take away this, again, as said previously, a problem fully defined is nearly solved. And so the main areas that we can really have an impact is really being able to integrate within an established patient or participant established workflow, making sure that it's in line, and aligning the system and whatever our solutions are around the user.
Awesome. Thank you so much. So with that, we have about 10 minutes left. So I wanted to just quickly turn the presentation over to Kim Rawlings from CMS just to talk a little bit about the Meaningful Measures framework and how human-centered design and person-centeredness in general kind of fits into that more global strategy around measures.
Thanks, Brenna. This is Kim Rawlings, and I'm the lead for the Measures Manager as well as the staff member, one of the staff member working on Meaningful Measures. And so it's really a privilege to be able to work not only through the process of measure development and how that really be able to get involved in the creation of those details, like some of those that Jay described, but also be able to kind of step back and really help to direct the future state of quality measurement for CMS as well. And so I do want to try and be brief just because I want to make sure we get to some some questions, but wanted to try and connect the dots a little bit among these presentations that we've just heard and really reiterate our commitment to patient-centered care and patient-centered measurement. And so I'm sure many of you have seen this diagram before. It's a really great depiction that shows how all of the CMS priorities and initiatives really fit in together and how they really give context to all of the work that we do. We've done countless listening sessions, I believe, early on in her position, the administrator did kind of a tour, talking to patients, talking to their caregivers and their families, et cetera, really to hear what was concerning to them. And that's how some of these things got on the list, really, prioritizing rural health, prioritizing data and having that access, lowering drug prices, et cetera. And when we look at this, we can see that foundation of empowering patients and that being core to everything and kind of wrapping around all of these different initiatives to really support it. Same thing with focusing on results and unleashing on innovation. And by focusing on results and unleashing innovation, that then really kind of bleeds into and supports empowering patients. So it all really works together to really help us achieve all of these various initiatives and priorities. And so both speakers really outlined some concrete processes, human-centered design processes, and kind of decision criteria to help ensure patient-centered measurement and patient-centered care and making sure that we get that voice of the patient. But not only that, it gives us high-quality measures that are, and really drives us to having outcome-based measures where possible, because health outcomes are what patients really care about. They don't necessarily care about, oh, did I get the aspirin within X amount of time? They care about, did I recover? What's my functionality, et cetera. And so when we think about meaningful measures and the objectives within that, patient-centeredness really feeds into that and really supports it and is really the underpinning of making sure that we are thinking about what's most meaningful to patients while keeping in mind some of our other objectives and goals that have an impact on other stakeholders as well. And the framework is something that everyone has seen time and time again. And, but I did want to show this again to really illustrate just one more time that in this diagram, the patient with their provider is at the center of this and really at the center of how we think about what our priorities are moving forward and around the actions that we take as far as what the measures we're developing, keeping in our programs, et cetera. All of those decisions, the patient is at the center of that. And, when we're thinking about, when we're thinking about changes to this framework, which I know some of you may have heard myself or others, starting to talk a little bit about like Meaningful Measures 2.0 and redesign of the framework or priorities moving forward, et cetera. We definitely got a lot of feedback and input on this one, but that's definitely what we're trying to do in 2020 as we are 3 years into this initiative, really trying to focus our efforts and get that feedback. And patients are definitely one of those groups that we're looking to provide that feedback, especially at the upcoming CMS Quality Conference, et cetera. There are a couple of sessions focusing on the future of quality measurement and some great listening sessions, et cetera, where we're looking to hear that feedback so we can incorporate it into the future editions of Meaningful Measures. And then, like I said, they also, patients and their families and caregivers really help us too to help us set our priorities moving forward. When we're looking at our priority measure types, the two main things that we're looking for is one, patient-reported outcome measures. It doesn't need to be said that those will bring us more patient-centered measures and really getting to the crux of what's important to the patient and having them dictate to us directly, what was your experience? What are your health outcomes? What's your functionality, et cetera, and really trying to listen to them directly to get that feedback and then feed that feedback into our existing programs, et cetera, when we include those measures into our measure sets. But also, I think there's a really good argument for ECQMs and how they are and can be patient-centered as well. Just the idea of EHRs, really having the patient at the center and interoperability, all of that, really will move forward as we continue to drive additional ECQMs, both their development and drive additional ECQMs into our programs. And then lastly, some of our measure priorities moving forward are ones that we've heard from people about that is what's on their minds currently. Maternal mortality, really hot topic right now and a lot of room for quality improvement, and that comes directly from listening to people. Same thing with opioids and nursing home infections, et cetera. So the goal here, really is to reflect what's on people's minds, what are the health outcomes that people feel like really need to be improved to improve their health and their functionality and the health and functionality of their family, et cetera. So I will pause there and turn it back to Brenna.
Thanks so much, Kim. All right, well, we have about 2 minutes left. And we have started to get a few questions in via the Q&A feature. So I think in the interest of getting at least one of those questions answered, we will not unmute the line. So if you do have any questions, please feel free to put them in the Q&A feature and we can follow up with you via email after. So this question, I can probably take a stab on answering if Jennifer's audio isn't working, but Jen, I'm gonna float it for you in case you do have it. The question is, what distinguishes HCD from participatory research or grounded theory methodology that's often used for similar purposes?
Can you say that one more time?
Sure. The question was, what distinguishes human-centric design from participatory research or grounded theory methodology that's often used for similar purposes?
I haven't used those methodologies personally. Jay, I don't know if you have any experience with that you could speak to that a bit better than I could.
This is Jay. don't have experience with those either, but I can consult with our team internally and share some response.
Yeah, actually, we have somebody, Maureen Hammer is on our team here and has some experience with that. So Maureen, do you want to chime in with a response for that?
Sure, thanks. So HCD uses participatory research in the empathize phase. So people are part of the research project and process, in fact, the core of it. Grounded theory techniques come into the define and ideate portion. So what is the data really telling us, and can we create a theory that addresses that? Then HCD uses that data that they've collected to prototype and test the solution. Did that answer your question?
Thanks, Maureen. That's great. And well timed, because we are now at the top of the hour. So in the interest of everyone's time for this afternoon, we will let you go. So thank you to all of our presenters for a great discussion today. Thank you for those of you who included questions and comments. We will follow up with you via email if we didn't get to your question today. And have a great one. We'll talk to you guys in a couple of months. Bye, everyone.